All right, great. Good afternoon again. My name is Andy. Today we're going to be talking about methadone maintenance therapy and an opioid treatment program, OTP. Basically, it's a fancy name for a methadone clinic. Next slide is my contact information. By all means, if you have questions after this, feel free to reach out to me. I'm always happy to help. If you can go to the next slide. So currently we have 10 opioid treatment programs in Maine. On the left, I've named them all, and you'll see there's bullet points underneath them. A lot of these facilities have been bought by bigger health conglomerates and changed their names. I don't really know how they exist. A lot of them go by two names, so I've tried to give them both there. But starting east to west in our state, we have a facility in Calais. There's 3 in Bangor. There is 1 in Rockland, 1 in Waterville, and then Lewiston, Portland, South Portland, and Westbrook. Some of these offer buprenorphine treatment as well, but today we're just going to focus on methadone. Most clinics have early morning to midday hours. So if you want to contact them, unfortunately, the best time to do so is first thing in the morning, when usually you have the most things on your plate that need to be taken care of. Most clinics start somewhere around 5 in the morning and get done around 11 to 1, some of the later ones. One thing I'll throw out here too, OTPs are not pain clinics and cannot take referrals for pain management, specifically pain management. I know there's a lot of, we have a large population of people that have addiction issues and pain issues, but none of the OTPs are going to be able to help you just specifically with pain. Next slide, please. So when you enter a methadone facility as a patient, to be eligible, you have to be at least 18 years old, and you have to have been addicted to opiates for a year. The key term there is addicted. You can't be a recreational user. You actually have to be addicted. We want them to show up at intake for treatment in a state of withdrawal, and this is a safety thing for patients. We don't want any opiate naive patients entering treatment. When you show up for day 1 for your intake, the first thing you do is you meet with a counselor. The counselor is going to do a complete, comprehensive psychosocial evaluation, which is a mental health history and a drug use history. In the drug use history, we're looking for a progression and increase in drug use, again, to demonstrate that the patient is not opiate naive, and that they can handle being in the treatment. While they're at our facility, I don't know, other places may do it differently, but we do a urine drug screen, which I forgot to put in there, and they get a TB test day 1. They also get a basic lab panel, and they get a syphilis screen as well, but that's done at another location. Then they also meet with our physician that's on staff that day. They get a general physical, and then once they do all that, they start dosing. Their first dose is no higher than 30 milligrams, and that's a federal guideline. The 30 milligram dose, also, we're going to talk more about it, but the 30 milligram dose starts them in their induction dosing in the clinic's dosing protocol. That 30 milligram dose usually for most people doesn't even give them any relief, from their symptoms. Sometimes they can get as long as 3 hours, but usually it's not very much at all. We start slow and work our way up. Once they enter treatment, counseling is a big part of how this whole system works. You can't have one without the other. The first 45 days, they get 4 hours. 60 days, they get 3 hours. 60 days after that, they get 2 hours. And then they do an hour a month thereafter. It doesn't matter how long you're in treatment for. You got to do a minimum of an hour a month. How we do it at our clinic is for the first 30 days that we have a patient, they get a card so that they come in and they see a counselor before they dose. This just helps, especially with new patients, helps the counselors and staff figure out what they need, if they're getting their needs met, and helping patients move through the program. The counseling education is primarily done in group settings. You can get individual counseling, but unfortunately, we have too many patients and not enough staff to offer individual counseling for every patient. Next slide, please. So this brings us to dosing for opiate use disorder versus pain management. So when you're in an OTP, you dose methadone once a day. Induction dosing is the most dangerous time of treatment. That's from the first dose, that up to 30 milligram dose, until we get a patient stabilized. And stabilized means they have no symptoms for a full 24 hours. They're basically considered induction. The reason this is so dangerous is that because they are dosing methadone every day, and methadone has such a long half-life, they can still have plasma level increases every 5 to 7 days, even if they have not changed their dose. It's still accumulating throughout their tissue. Average daily methadone dose is 80 to 120 milligrams for maintenance. Again, this is kind of a national average. You'll see people on the low end of that spectrum. You'll see people on the upper end of that spectrum. I threw that out there because it used to really freak me out when I didn't know anything about methadone to see people on 180, 190, 230 milligrams of methadone. But unfortunately, that is a stable dose for some people. If you were to use methadone for pain, not for opiate use disorder, you'd have to dose it at least 2 to 3 times a day for it to give you pain relief. Which brings me to the next slide. So, coordination of care. The methadone dose that they get once a day basically just keeps withdrawal symptoms at bay. It doesn't provide any, or it will provide very little, if any, analgesia for acute pain. If you have a patient that you see in an emergency type basis, they can be treated for acute pain while they're in treatment. Again, it comes down to a lot of other decisions, but they can be treated. It doesn't affect their care at our facility, and it doesn't derail their treatment for their addiction. If you do treat a patient for pain, they may need a higher dose at short intervals than you're used to dosing other patients with. And it's because they're addicts, they have built up all these receptors, and they can just go through a lot of medication in a much shorter time than a normal patient would use. We advocate that they disclose that they are in treatment. Sometimes they don't, but if a patient comes to you and is telling you they're on methadone, they're telling you because they've entered the system at rock bottom. They've worked their way through. They're stable. For a lot of people, they've gotten their lives back on track. They're working. They've gotten their kids back, their families back together. And they're telling you this because they don't want to go back into the depths of what they have just removed themselves from. At our facility, we have a variety of people that can answer questions for you. And so please, use us as a tool. Get information from us. That's what we're there to do. And if you want to go to the next slide, I've thrown a couple resources out here. The top one is the U.S. Department of Health site for medication treatment, medication-assisted treatment. This has methadone and buprenorphine. It's pretty standard stuff, but it can give you a lot of links to resources. The one below this, full disclosure, is a site that is maintained by a company called Mallinckrodt, which is a drug company. They manufacture methadone and some other opiates. A lot of your oxycodone, your generic Percocets made by Mallinckrodt. So it is a company-owned website, but they have a lot of really good information specifically about methadone and dosing and a lot of good stuff that you can get there.